So on behalf of AETCM, today we are going to present an interesting case, my polymyositis. The presenter is Dr. Manna and our other postgraduates Dr. Riaz and Dr. Vivek also taking part in the clinical presentation, case discussion. And our HOD is coordinating this one, Dr. Professor Girish.
Please.
Thank you, sir. A 45-year-old male patient was brought to our ER with complaints of body pain since past 25 days. On initial 10-second assessment, patient was conscious oriented, was answering to my questions. Airway appears patent and there is no pooling of secretions. Breathing, he was tachypnic with a respiratory rate of 26 per minute and he was using accessory muscles of respiration, but its saturation was 100% in room air itself, and bilateral air entry was equal. Circulation, his heart rate was 112 per minute with a blood pressure.
See, one thing, airway appears to be. So either airway is patent or not patent.
Patent.
You never say appears to be, because it's a vital structure and should be tell us. Number two, see, when you are discussing about the breathing, never forget to say about the ventilatory excursions, whether adequate or inadequate. Because the patient is having accessory muscles in action. That means the chest excursions may not be adequate. So always two things never forget to mention. Okay, good.
His heart rate was 112 per minute with a blood pressure of 140/90 with a MAP of 103. All peripheral pulses were felt equally and bilaterally. Disability, his Glasgow Coma scale was E4V5M6 with a pupil of 2.5 mm reactive. Exposure, his temperature was 98 degree Fahrenheit with a GR base of 112 and hypothermia was prevented by blanket. At this point of time, since he was tachypnic and there was tachycardia, so I asked for a arterial blood gas analysis which was showing a pH of 7.404, PCO2 of 25.7 and bicarbonate of 15.7 and the lactate of 2.2. So it is actually and it was a high anion gap metabolic acidosis which is compensated, sir. And in our ABG machine we can see the electrolytes also, and potassium looks like 5.7. It was 5.7. It was high. So I immediately asked for a ECG to look for hyperkalemic changes.
Why this high anion gap acidosis?
Maybe because with the history of body pain, so initially we were suspecting something like an acute kidney injury which is causing this metabolic acidosis, sir.
Anything else is possible in a elderly male? Alcohol, toxic, methanol, ethanol. All these things we should suspect. I am not telling that is a diagnosis. When somebody is coming like this, we have to suspect all these things. Lactate is 2 only.
2 only, sir. ECG was taken. ECG was showing only sinus tachycardia. There was no hyperkalemic changes. Then I went ahead.
What changes you expected in hyperkalemia?
First change will be a tall T wave, sir. Then there will be progression of QRS, PR prolongation and absence of P wave. Then at last there will be sine wave pattern. Then I went ahead with the sample history. There is no history of any allergies. Patient is not on any medications, no other significant past histories, and patient is not an alcoholic or a smoker, sir. Then events which led to this was 25 days back he told that he had a strenuous exertion of climbing a 5-floor building. After that next day he developed body pain. Initially the pain was on the lower limbs.
Only once he climbed, so may not produce that much muscle problem. Suppose he climbed continuously for many hours. There are some conditions called as March hemoglobin. Mainly occurs in military persons, police or athletes. Okay, they are continuously producing strenuous exercise in a non-trained person can produce some amount of rhabdomyolysis, and that can present like this. Okay, but he has climbed only once.
Next day he had this lower limb pain. Because of that he was able to climb only 2 stairs, and progressively on the other days he was having difficulty in walking, and after 10 days he was fully in the bed taking rest for this pain. And he noticed that after 10 days his urine output started reducing, and he had on and off fever also in between. So he was taken to outside hospital and he took some oral medications and IV medicines, but there was no history of any NSAID intake.
What is the occupation?
He's actually working as a gold merchant, sir.
Okay, good.
Otherwise there is no history of any weight loss, trauma, difficulty in swallowing, breathing difficulty or vomiting, sir. Head to foot examination, his face look erythema over the face is there. Otherwise there was no other skin lesions. Central nervous system examination, higher mental functions were normal. Power, bilaterally power was actually 4/5 in all 4 limbs, and there was tenderness on palpating the muscles.
You want to check the power of distal muscles or proximal muscles in myopathy?
Both, sir. We should.
Very rarely myopathy is
Pati.
present distal muscle weakness. So hand grip and all mostly it is normal. But proximal muscle weakness is the classical presentation of any myopathy.
Yes, sir.
But inclusion body myopathy generally present with distal weakness.
Distal muscle power was normal. Proximal muscles was actually 4/5, sir. Then
What is Gower sign?
Gower sign is seen in
use his own body to get us.
Okay. That's a classical finding of proximal myopathy, including all type of myopathy seen in diabetes and all. Okay.
Duchenne muscular dystrophy.
Every muscle dystrophy, that is a classical sign, but some patients will not be able to do it. That's all.
Okay. Then reflexes were normal, sir.
Okay.
Then sensory system was normal, and I examined the other system. Respiratory system was examined. Respiratory system, even though he was tachypnic, he was using his intercostal muscles to breathe, but bilateral air entry was equal, and there was no added sounds. Cardiovascular system and
You want to do a single breath count?
Yes, sir.
Okay. That is mainly for documentation. On admission, you document a single breath count. In subsequent days, again you document it. If the patient is deteriorating, his muscle weakness because of diaphragmatic weakness, if the single breath count is coming down, then that's an indirect evidence of respiratory paralysis.
Yes, sir. With this complaint, he was admitted. So initial our impression was to was a rhabdomyolysis with the features of developing an AKA. He's going to an AKA with and fever
When
with
you
myalgia.
think about rhabdomyolysis, you should know the causes for rhabdomyolysis. What are the causes?
Causes, it can be a strain, that means maybe because of a trauma or crush injury or burns or some drugs or even use of alcohol.
Some drugs means what drugs?
Drugs mainly statins, steroids.
Common used drug in our practice is statin. Okay.
Then exertion, seizures, all can go into rhabdomyolysis.
Okay. Muscle, viral fever.
Yes, sir.
Many viral fevers can, including dengue fever, can have rhabdomyolysis because of the polymyositis. Okay.
So he was admitted in the ICU. Then his CBC report came. His total count was 4,000, sir, with a CRP of 3, and platelet was 1,50,000. His potassium was 5.2, sodium of 125, and first creatinine value was normal, sir, 0.78, sir.
Okay.
Then in view, then his LFTs must, so OTPT was mildly deranged.
CK?
Total CK was 27,000.
The problem with this CK is here if you do CKMB, that also will be elevated. That should be never considered as an acute myocardial infarction. This is one of the major problem occur in clinical practice. When you see the CK elevation, when you try to do CKMB without any clinical evidence, then CKMB also will be proportionately elevated. So that should not be taken as a marker of myocardial injury. There may be some injury.
His patient's CKMB was 38, sir. If it is less than 5%, that means it is usually considered as so initially we sent for the infective panels. So lepto was sent, sir. Lepto IgM became negative. Then dengue NS1 was negative, but IgG was positive.
IgG positive means what?
Recent infection. That means he's
Past
getting better.
Past. Not recent. Past. Recent is always IgM.
Then malaria, viral test, everything else was negative, and with the CK value of 27,000, so our differential diagnosis was a rhabdomyolysis or post-infectious
polymyositis secondary to an infection, or polymyositis, that is idiopathic polymyositis, or polymyositis secondary to some other immunological disorder. We don't know what it is, but it is polymyositis and rhabdomyolysis. elevated CK indicates that. Creatine, what happened to the creatine?
Creatine, in the next value, creatine became 1.13, sir. It was
Slightly
increasing.
No.
So,
Urea?
initially it was 27, sir. Then it started elevating to 56,
Okay.
like that.
You may not get normal rise of urea in polymyositis. What is the reason for that? Urea is produced from where? It's produced from the muscles. So somebody is already lost good amount of muscle mass. You may not get an elevation of urea. So never think that urea elevation can be there in polymyositis. Initial phase you may get it, but if it is a chronic thing, you may not get it.
So he was subsequently admitted in ICU, and he was started on IV fluids, sir. IV fluids almost 400 ml.
Why we are giving IV fluids?
IV fluids, there can in this condition there will be third space loss will be there, and
there is no
hypovolemia.
BP
Rhabdomyolysis.
IV hydration.
Why? What is the reason?
Sir,
Rhabdomyolysis, this muscle loss is there. This excessive things will precipitate kidney injury. So we have to force alkalinity.
So you have to remove that through the kidneys. Otherwise, kidney it will precipitate in the kidney and produce kidney damage. That's why we are giving IV fluids.
And he was catheterized, but his urine output was very low, sir. Hourly only 10 ml of urine was coming out. We are actually our target urine output is almost 200 ml per hour, but urine output was very much less. So we had to start him on furosemide infusion. And even after furosemide infusion, his output was very less, sir. Maximum 600 ml per day. In the progressive days, his potassium was elevating. Even after hyperkalemic measures, potassium was going up to 5.5 to 5.7, and other parameters, total counts was initially 4,000, which was increasing to 18,000, 23,000. Like that, counts also were increasing. So, in view of this, and we to rule out rhabdomyolysis, we sent for a urine myoglobin, which was negative, sir. So we ruled out rhabdomyolysis. So we were suspecting it to be a polymyositis, maybe because of post.
You cannot completely rule out rhabdomyolysis only on the terms of urinary myoglobin. Sometimes it may not be secreting because of the kidney failure, ongoing kidney.
Then we suspected polymyositis. The polymyositis itself, this vasculitic conditions are there, like polymyositis, dermatomyositis, and all.
That is a different issue. Polymyositis is basically divided into primary, that is idiopathic, and secondary. Secondary again divided into drug-induced or post-infectious. Third one is polymyositis as such. That's a autoimmune disease. We'll discuss that afterwards. This is polymyositis. Now you have ruled out drug history. You have ruled out possible viral infection. Still, viral infection might have occurred before that because it's a trigger for immune-mediated polymyositis. So that is possible. Third one is your immune-mediated polymyositis. Okay.
So
there only that 5 classification comes.
Okay.
What are the classifications?
Polymyositis, dermatomyositis, and inclusion body.
Inclusion body myositis is a separate entity. Polymyositis, dermatomyositis, that is primary. Polymyositis or dermatomyositis, depending on the secondary disease like rheumatological disorders, then induced by malignancies. Okay, first one is polymyositis, second dermatomyositis, polymyositis, dermatomyositis, all are idiopathic. Then secondary causes are there. Inclusion body myositis is a different entity, but it also comes under polymyositis. Okay.
Then drug-induced and autoimmune conditions. To rule out autoimmune conditions, we sent for a ANA level and anti-Jo antibody level, sir, which came positive for this.
Anti-Jo antibody is a confirmatory test for this immune-mediated polymyositis. ANA will be positive in this or many other conditions also ANA will be positive. So it is not a dependable investigation. Okay. Now what are the investigations you do to rule out other conditions? It's a 45-year-old male.
Malignancy should be ruled out.
What
sir.
are the basic investigations you do?
Malignancy, CT chest, CT
you
abdomen,
look for any lymphadenopathy, CT chest, ultrasound abdomen, chest X-ray, prostate enlargement, all these things we can check. For immune-mediated disorders?
Antibody.
DHDNA, like that,
Anti-RO,
SCL
SC.
antibody, RO, LA, SSB, like that, different antibodies can be tested if there is a clinical feature. Is there any dermatomyositis features in this patient?
Only lesion is a patient is having erythema over the face. There was no helicotropic lesions
Helicotropic
were
rashes, okay.
were not.
Now the most important problem in this patient will be if this patient in emergency room requires some mechanical ventilation. Sir can ask detail about it.
What is the associated complications do you expect in myositis patients before we go into the intubation part? Anticipation.
Yes, sir. This patient is having muscle weakness, sir. So we should
Number one,
anticipate
muscle weakness. Okay.
muscle weakness is there. From the head, and if we are starting there, if this patient is having some autoimmune condition, mouth opening will be affected, sir.
One. Okay.
Then involvement of the pharyngeal muscles will be involved, and lower esophageal sphincter, if it is weakness, there is a risk of aspiration also. Mouth opening will be
For
difficult.
this case, there any cranial nerve examination gives any clue?
It was normal, sir, for
normal.
this patient.
Okay, as such normal.
Normal.
So because of the muscle weakness with the extension, see the keeping the position in the sniffing position for intubation may be difficult. Sometimes mouth opening may also be difficult. Third one, as she told, the pharyngeal deglutition reflex. So the chance of aspiration will be more, and esophagogastric reflex because of the esophageal sphincter will be lax. So the chances of aspiration again. Good. Any other thing? Next.
Then this patient is having hyperkalemia, sir. So
Okay,
we
number
should
two,
avoid
hyperkalemia.
agents like succinate.
Hyperkalemia, what is the present value and what is the normal value? It is very
Potassium,
high.
it was always in that 5 level, sir.
No,
More than 5.
5.7.
Okay, then. Number 3.
Neck extension.
That is okay. Regarding the breathing or ventilation part,
ventilation part. This
it
patient
should be
will be having
insufficient. Okay,
insufficient
hypoventilation because as she told, only intercostals are acting. Diaphragm is not acting. Okay, the patient started having.
tachypnea.
So what will be the next stage? Once the patient is using the accessory muscles of respiration, the patient may go for respiratory failure. So you have to keep in mind, and you could have started a earlier administration of oxygen and assisted ventilation also. This patient's breath is not enough, so you have to go for a assisted ventilation. What is the difference between assisted ventilation and the other one, controlled ventilation? Is there any difference?
Assisted ventilation means patient will take breaths.
Triggering patient. No, we will support each and every breath he is making attempt. We will be making it to complete. Okay, this is the assisted. Controlled.
Control means once patient is fully paralyzed, we will take full control and we will give breaths.
Either paralyzed or respiratory failure. So we have to totally take care of the ventilation. Okay. So the one important thing you have to keep in mind in the assisted ventilation is paralyzed, no problem. You are going to ventilate. Only thing, the pressure should not be over-inflating the stomach. So here you have to synchronize the patient's inspiration with your squeezing of the back. This is the most important thing you have to. Otherwise, you will produce paradoxical respiration. Okay. Any other thing? So regarding this is the regarding the intubation part, the selection of the induction agent and muscle relaxants.
Induction agents, etomidate can be used.
Etomidate can be used. Okay.
And paralytic agent usually
induction with analgesic.
Analgesics.
Don't forget.
Yes, sir.
So etomidate.
With fentanyl can be used.
Very good. Always combine E and F. Okay. Etomidate and fentanyl. Then
paralytic agent.
Other choices. Ketamine.
Ketamine. This patient is having tachycardia, so we are avoiding.
Okay,
Better to avoid. Then propofol can be used.
Patient BP is normal.
Normal, sir.
Okay, so etomidate is a good choice. No problem. Then regarding the muscle relaxants.
Muscle relaxant. This patient
for intubation.
Intubation. Other than succinylcholine, then we will go for rocuronium can be used, sir. Only thing is they might be having prolonged paralysis.
Individual variations in the duration of action. As such, for myositis, they find that even succinylcholine is not causing any arrhythmias or anything, unless there is the potassium value is very high initially. Myopathies, we have to avoid succinylcholine. And the myopathies, the most important, then these patients may be going for malignant hyperpyrexia. So this is one of the things, so we have to avoid this one. Okay. So rocuronium is an ideal choice, and then post intubation maintenance also you have to keep in mind. These patients mostly may need ventilator support. for longer duration. Any other complications do you anticipate? The lung infection, lung complications are more in these patients. Those who are having myositis or dermatomyositis, lung complication, whether interstitial lung disease or alveolar lung disease or bronchopneumonia, this is one aspect. And as such, myositis, cardiac muscles also being attacked, also affected. So there may be conduction block. So you have to continuously monitor the ECG also and take care of this cardiac part also. So this is okay.
How do you manage this polymyositis now?
From airway breathing circulation, sir. If the breathing is inadequate, we should supplement, assist the breathing, sir. If a patient is very tachypneic with the full sensory, we can plan on non-invasive ventilation, sir. Then circulation part also we should take care. Then treatment.
This patient is having tachycardia. What do you suspect?
Maybe associated carditis or
myocarditis, post-viral myocarditis. Which drug may be beneficial in this patient?
Beta blockers.
Beta blockers, small dose of beta blockers may benefit in this patient. How do you treat that polymyositis?
Polymyositis mainly high dose of steroids are usually indicated. Methylprednisolone is usually advised, sir.
1 gram.
1 gram is the pulse dose.
Into 3 days.
Other
you are giving dexamethasone?
Dexamethasone equivalent dose is 8 mg of methylprednisolone corresponds to 1.5 dexamethasone.
Normally when we give pulse dexamethasone, 40 milligram we give. Only advantage is it's very cheap. Okay, comparing to methylprednisolone, it is cheap, and the side effect profile is same, both methylprednisolone and dexamethasone. Fluid retention is less comparing to methylprednisolone in dexamethasone. Okay.
Duration to actually if we are starting at one, usually we will give for 6 weeks, sir. Then we will be
steroid 3 days full dose, that is pulse therapy. Then 1 to 2 milligram per kg body weight normal steroid that bisolone can be given. So 60 milligram we give for this patient. Then taper down over 6 weeks. Okay. What are the other alternating drugs? What is a common side effect of steroids on muscles?
That itself can cause
myopathy. It can improve drastically, but after some times it produces myopathy. So nobody will continue on steroids for any of these patients. What are the alternating drugs you can give in emergency room?
Sir, methotrexate, azathioprine.
Methotrexate is a continuation drug, immediate effect. Rituximab can be given in emergency room. You can start like it's pulse therapy, biological drug, that can be given. In continuation phase, you can put him on methotrexate. Methotrexate alone, or you have to give folic acid. Okay. What is the common side effect of methotrexate? How do the patient come to emergency room on methotrexate? Hepatotoxic is okay.
GI toxicity, bone marrow suppression.
Bone marrow suppression is most important. Many patients may not take this folic acid. In that case, what is the treatment?
We have to keep
folic acid. Active form of folic acid, that is 25 milligram is available. You give BD dose into another 5 days. Okay, that can be given. Or you can give other drugs like azathioprine, mycophenolate mofetil. All can be given in polymyositis. You have to investigate for other malignancies and other diseases. Okay, rheumatological diseases. Young male, you have to investigate for different type of microvasculopathies also in this case. Okay. Most of the most common disease is always viral fever and viral trigger that can trigger polymyositis. Sometimes you get an answer for this triggering disease like rheumatological disease or malignancies. Okay, anything else? How is the patient improved?
Patient's just result came, sir. So we have to plan for a muscle biopsy.
Next one is muscle biopsy. What is the role of MRI in this patient?
MRI of the muscles can be.
MRI can be given if required. Otherwise, we can take a muscle biopsy to confirm the diagnosis. Okay.
An electromyogram.
EMG can be given. Okay. What is this one? Critical illness, neuropathy and myopathy. Is it same as polymyositis? It's commonly seen in ICU.
ICU, prolonged ICU stay, sir. Patient will be developing foot drop, then diaphragmatic.
Critical neuropathy means foot drop, they come. Diaphragmatic weakness, difficulty in weaning from ventilation. Myopathy same, proximal myopathy.
Yes,
but there also the treatment is steroid. There is a only issue. There is no other treatment. Physiotherapy, steroids. Okay. Thank you.